Good evening. Thanks for joining. We are hosting this webinar for our multiple myeloma and Waldenstrom's macroglobulinemia patients and their friends and families. My name's Annie. I am a clinical research coordinator on Dr. Irene Ghobrial's team here at the Dana-Farber Cancer Institute. The goals for today's webinar are going to be to answer some pre-submitted questions on MGUS, smoldering multiple myeloma, and Waldenstrom's macroglobulinemia. We're also going to answer some questions and kind of demonstrate the experience of being a multiple myeloma patient. And we're really hoping that this will be a support network for all of our patients, their family and friends who are at home right now during the COVID-19 pandemic. So we will be answering questions on that as well. So with me today, our team includes Dr. Irene Ghobrial, who is an attending hematologist at the Dana-Farber Cancer Institute in Boston. She is a professor of medicine at Harvard Medical School and the director of the Center for Prevention of Progression of Blood Cancers, which we call the CPOP Clinic. She specializes in multiple myeloma and Waldenstrom's macroglobulinemia, with a particular focus on the precursor conditions which precede these two blood cancers. Thanks for having us. Thanks for being with us today, Dr. Ghobrial.
Thank you, Annie.
Next up, we have Dr. Hearn, who is an attending physician at the Mount Sinai Tisch Center Institute and is an associate professor of medicine at the Icahn School of Medicine at Mount Sinai in New York City. He's also the chief medical officer for the Multiple Myeloma Research Foundation, or the MMRF. Thank you for joining us today.
Thanks for having me.
And we also have Mr. Ethan Hawes, who is a multiple myeloma patient advocate and a PROMISE study ambassador. Mr. Hawes was diagnosed with multiple myeloma in 2013, and since his remission, he's dedicated a great part of his life to supporting other myeloma patients and serving as a community educator. Thanks for being with us, Ethan.
Thank you for having me.
Perfect. So I just want to kind of go over a couple of ground rules before we get started. Number one is that we did receive a notification from YouTube that there's been an increased number of live streams due to the COVID-19 outbreak. For this reason, we are recording the session today. So if you end up losing us or we go off stream in some way, it will just end up being a recorded session that we post later rather than being live. So don't worry about that. Either way, you will get all the content that's going to be on here. And secondly, if you're interested in asking a question from either anyone here, we do have a great team that's working behind the scenes to organize the questions that we receive in real time today, as well as if you have any issues with technical difficulties. So to ask a question, you can either type it into the YouTube chat box. And I just want to make a note that this is a public chat. So anything you put in there, everyone else will be able to see. We're also monitoring our inbox, which is precursor@partners.org. That's precursor@partners.org. It's also on our PCROWD website. And if you email us a question, we're going to assume that you wish to remain anonymous, and so we will honor that wish. And then finally, we might not be able to answer every question. I know we've already gotten a lot, but we'll do our best to answer as many as possible. If you have a highly specific and personalized treatment or symptom-related question, our team is recommending that you reach out to your hematologist, oncologist, or your primary care physician. Okay, so thanks for joining us. We're going to kind of follow a series of steps. We're going to start with questions that were submitted over the past week and have our physicians answer those. And then Ethan's going to give a little description on what it's like to be a myeloma patient and answer some of those patient-related questions. We'll then talk about some COVID-19 related questions and finish it off with anything that comes through on our live chat. So with that being said, I just want to make sure everyone's on the same page and that we're all using the same acronyms. I wanted to start by asking Dr. Ghobrial to give a brief explanation on MGUS, smoldering multiple myeloma, and multiple myeloma.
Sure, Annie, and I just want to thank everyone who joined us right now because it's really a wonderful way for us to all communicate again and all of us socialize despite all of the distancing we're doing. So I want to say thank you again, everyone. I do want to thank the MMRF for supporting us and being part of this because it is important for all our patients, not just the MGUS and smoldering, but overt myeloma and everyone here who's on this call or on this chat. So I'll start with definitions. As Annie said, MGUS, monoclonal gammopathy of undetermined significance, big long name. And it's really a precursor of multiple myeloma. So if you think about myeloma, when many of us many of you have the disease and come in with bone pain or anemia, most patients would have had a period many years even before that where they were asymptomatic, they didn't know that they have it, and they have an early precursor condition called MGUS, or another one that's just before myeloma called smoldering multiple myeloma. And MGUS was actually described by Dr. Bob Kyle, and Dr. Kyle is really the grandfather of myeloma. And I love to say that I trained with him at Mayo Clinic. So it's wonderful to think about it. And he described it over 50 years ago or so when he saw people who have a small little protein in their blood, the monoclonal protein that we all know that patients with myeloma have it, and a little bit of plasma cells in their bone marrow. So people said, well, this is myeloma, yet the people had no anemia, no lesions in their bones, no kidney disease, no other problems. And actually him and other physicians were arguing whether this should be called a benign gammopathy that will never lead to myeloma or something else. And he was so good in thinking of the process and of potentially developing myeloma that he said, let's not call it benign gammopathy, let's call it monoclonal gammopathy of undetermined significance, because they may indeed develop myeloma in the future, and let's follow those patients to understand their disease progression. Now, at the same time, he said, let's not overtreat patients too, and watch and wait. Potentially in some of those patients could be important because they may never develop myeloma. So it's very important to have that balance between should we treat early, and we'll talk about that a lot, and should we watch carefully so that we don't do harm. Now, once the patient has more than 10% plasma cells in the bone marrow, and many of us could say, well, that's a very arbitrary number because I could be 9% or I could be 11%, and it's the same patient at the end of the day. But let's leave that apart. But once you are 10% or more in your bone marrow, we call that smoldering multiple myeloma. And just like the name says it, it's almost myeloma. It's a smoldering fire that's ready to go on. And the question is that within that group, within smoldering myeloma, many people look more like either MGUS or look more like myeloma, which means that it's a very heterogeneous disease. And that's why, again, it's very important for us to talk about it. Some people may need therapy very early before they develop disease, before they develop end organ damage, and we'll talk about that. And some people may not need treatment, and we should watch them carefully and avoid giving them a toxicity.
Perfect, thank you. So a lot of our viewers right now are probably from our PROMISE and PCROWD studies. So Dr. Ghobrial, can you please explain what those two studies are and how do people participate in them?
Yeah, and actually Annie is one of the leaders in the PROMISE study. So many of you who are PROMISE candidates or PROMISE participants, you get to see Annie for the first time, and she probably calls you and emails you 5,000 times a day. So it's wonderful to see her, and the rest of the team who's behind the scene are all really the ones who really do all the work. So PCROWD is our first study that we started, and we started it 5 years ago when we said, instead of having people with MGUS or smoldering myeloma coming to us at Dana-Farber, coming to the clinic, and then they give us the sample, and then we figure out what's going on, why don't we have an empowering way to give patients access to do research? And we said, let's have it online. There's no physician intermediate. We remove all the physicians. As much as I'm a physician, I think that we actually delay patient access. And let's have it all related to the patients. It's empowering patients 100% to be part of the research. So any patient who has MGUS or smoldering myeloma or other precursor conditions like early CLL, early MDS, who lives anywhere in the US, although now we're going to actually also have it international, not just in the US, you can go on pcrowd.org, sign up, and you can get a blood sample sent to you, a kit sent to you, and you can go when you're getting your blood drawn or your bone marrow biopsy done at any time point in your local doctor's office, you can send us that sample. And then we get information from you on how to get your clinical information back to us. So we have a big team working behind the scenes on getting all of your clinical data, annotating it, and attaching it to your blood sample. And because of that, we have now thousands of patients on the PCROWD. Originally, we said this is crowdsourcing for patients instead of for money, and it's truly crowdsourcing for patients who have made this an effort that's theirs. I know many of you are amazing PCROWDers who actually give us 20, 30 samples, and we are very proud of you because you make that research happen. And I can tell you, even today in the morning, we had a lab meeting talking about all of those samples and what are the great research studies we can do with that. Now, after we started PCROWD, and we were very excited about it because it can enable us to ask big questions. Who will progress in their lifetime? Who will not? Should we treat everyone or not? Can we develop better prognostic factors for people to understand better who will actually develop myeloma? We came back to a question of saying, well, people are diagnosed incidentally. You can go to your doctor, they find a high protein level, and they say, oh, maybe you have myeloma or MGUS, let me check for it. Yet people don't look for it. And I come back to the question of, if you're over age 40 and you go to your primary care doctor, usually they do cancer screening because we know that cancer screening saves lives. Yet we don't screen for myeloma. So you go and do a breast cancer screen with mammography, you do colonoscopy for colon cancer screening, yet no one told you, why don't we just do a blood sample and see if you have myeloma or you have MGUS? And we know that that's a very high risk feature in many people, in people who are African American of origin, in people who have a first degree relative of myeloma, yet we don't look for it. And I can tell you, it's easier to get a blood test than getting a colonoscopy or a mammography. So why aren't we doing it these days? And the answer is, let's actually screen patients to look for MGUS and smoldering, to look for myeloma, which is the PROMISE study, and see if we can track the patients, understand who will progress in their lifetime and who will not, and then go on to develop therapy for them.
Perfect. And you can check out both of those websites. They have pretty easy URLs at pcrowd.org and promisestudy.org. Dr. Ghobrial, I know that some people were interested in knowing what the results of the PROMISE study will do for current patients and whether there are screening options for children, particularly younger children in their teen or young adult years.
Sure. So the PROMISE study, and I didn't describe it in all details, it's 50,000 individuals who are at risk of developing myeloma, meaning African Americans over the age of 40 or of African descent. You don't have to be African American, or anyone who has a first degree relative who has a plasma cell disorder. So MGUS, myeloma, amyloidosis, Waldenstrom. You can go on promisestudy.org. You can register and see if you are eligible or not, and then we go from there. Now, having 50,000 people registering for this and giving us blood samples, we expect to have 3,000 of them to have positive results. And I can tell you already, and Annie can tell you this, we call every single patient who's positive. Some of them have overt myeloma. Some of them already have myeloma, and they were not symptomatic yet. But when they went to their doctor, they were found to actually have 60% plasma cells in their bone marrow, or a lesion, and they were not symptomatic yet, or more things. So already we're finding that we can catch myeloma early. That's one thing. The second thing that was very promising is we can also catch amyloidosis early. And I said that if we can do one thing amazing about this study is we can catch amyloidosis and treat patients early, because amyloid is one of the worst diagnostic features of plasma cell disorders. So if we can diagnose patients early and treat them early, we can make a difference in the survival of amyloidosis. But despite that, people who have smoldering myeloma, our hope, and truly this is our mission, is that we can treat you early before you develop CRAB criteria, before you develop end organ damage. And I usually say that, so many of you heard it before. I think that every other cancer, when you go to your doctor and say, I have lung cancer or breast cancer, they never tell you, you know what, you're asymptomatic, you're fine. Wait until you have metastatic lesions everywhere. Wait until you have fractures in your bones, kidney failure, and then I treat you. You would think that that doctor is crazy. Yet we do that every single day with myeloma. We tell you, wait until you have symptoms and then we treat you. So we need to stop doing that. We need to actually treat patients who will develop myeloma sooner or in the next few years and actually treat them early. Now, having said that, we don't want to over-treat people who will not develop myeloma in 10 years, 15 years with therapy that could be toxic. So again, there's a very good balance here, and we have to be careful not to over-treat, but not to under-treat patients too.
Perfect. And the PROMISE study and PCROWD study, I know a lot of other questions that participants are asking is whether these are ongoing through the current pandemic. And the answer is sort of. The PCROWD study, simply by the nature of it, is going to rely on whether the physician that you see is seeing patients right now. But the PROMISE study, we have open enrollment online. Anyone can enroll at pretty much any time you go through an eligibility criteria to see if you can participate. And we're trying to really ramp up the efforts on social media and virtually to get participants to sign up now, because as soon as you are signed up, you're ready to go, and then we can send you a kit when this craziness is over. So we're really encouraging you to tell your family and friends about that while everyone's stuck at home and can be online. So that's just about that.
I would say, Annie, that's a perfect example. You're sitting there with your family member had myeloma or is on treatment of myeloma. This is a perfect opportunity to talk to the whole family and say, let's all sign up. We're all sitting there. Let's do something useful, something important for us. And we were actually talking about all the potentially positive things coming out of COVID-19, although none of us think there are too many positive things, but one of them is, let's have an encouragement to sign up online. It's an online thing. You don't need to do anything else. We can get you to do the blood sample later on. But for now, if you're going to do one thing, sign up. And we would love to see a surge of people going on promisestudy.org and signing up. The other positive thing that maybe we can discuss it later on is we are doing a lot of virtual consults. We're now thinking of taking Center for Prevention of Progression, or CPOP, all of it online, giving you consults online, and doing virtual clinics. So that will come in the near future, but again, something that we really think is very positive from this craziness, as we said.
Perfect. And one last question about the PROMISE study is, you had mentioned that individuals who identify as being of African descent are eligible to participate. And why is that? Why are participants who are of African descent at a heightened risk for myeloma?
So we've known for many years that African Americans or of African descent have a higher chance of developing myeloma, 3 times higher than the Caucasian population. And yet we never knew why. We don't know exactly what are the causes. So there could be genetic causes, immunological causes, other causes that can lead to that higher incidence of myeloma. And what we know, which is important, is that there's a huge disparity also in the treatment and the survival of patients with myeloma who are African American. So we want to beat that. And in fact, we had a meeting recently with the FDA and AACR and foundations, including MMRF, talking specifically about what can we do for multiple myeloma, especially for patients who are African American or of African descent, and can we make a difference for them? And we believe that the PROMISE study is one of those options. If you sign up and you talk to your family members and you are encouraged to think about it, whether you have MGUS or smoldering myeloma, and we treat you early and we help you get access to care, that could be a huge step forward for us to beat up that disparity and make a difference for the survival of all of our patients.
Great. Thank you, Dr. Ghobrial. I'm going to bring in Dr. Shu as well to answer some of our treatment-related questions, which we are going to be transitioning to now as well. Let's see if I can make this. Perfect. Oh. Okay.
It's like the Hollywood squares.
All right. Give me 1 second. I'm going to play around with this. All right. Perhaps that's a bit better. Okay. So first off, if I could briefly ask you to kind of outline the treatment stages and phases for a myeloma patient. What are kind of the common treatment plans, the words that you would be looking for as a myeloma patient? And do MGUS and smoldering patients fall into these categories, or how do their treatment plans look?
So as Irene indicated, the standard of care right now for smoldering and MGUS patients, which we all consider to be woefully inadequate, is to watch and wait. Now, there are clinical trials for patients who fall into the smoldering myeloma category, and Irene and her team are among the leaders in that area. But there is no standard endorsed treatment for the treatment of smoldering myeloma right now. For patients who have symptomatic myeloma, the treatment falls into a couple of different phases. The first part is called induction therapy, and the intent for the induction therapy is to put the disease into remission. And fortunately, we have a number of different induction chemotherapy regimens that are very effective in putting the majority of patients into remission. There are next steps. Usually, we have to distinguish between patients who are eligible for autologous stem cell transplant, because that determines the next phase of treatment. So for patients who, in general, under the age of 70 and who have a few comorbid illnesses, we would consider them eligible for stem cell transplant. And we do that after achieving remission with induction. That's been shown in many studies to improve both the length of the remission and overall survival in myeloma patients. Typically, after the transplant, which is called consolidation therapy, the next phase is maintenance therapy. So a large majority of myeloma patients will receive an oral drug that they can take at home as a maintenance therapy after the consolidation therapy. For patients who are not eligible for transplant, they will often receive maintenance therapy after completing induction chemotherapy. So that's the general map from newly diagnosed myeloma patients. The map diverges down the road, and there's a number of different treatments available for patients who relapse after their initial treatment. So we're very fortunate in this era to have almost a dozen new medications that have been approved by the FDA for multiple myeloma over the past 15 years or so. When I started in this field in 2000, we really had only historic cytotoxic chemotherapy agents at our disposal, and the response rates and overall survival in those treatments were very poor. And now, after 15 years of clinical research, we have a broad array of really excellent medications, both chemotherapy drugs and now immune therapy agents, with more under clinical investigation that we expect to have available for clinical use in the near future.
And Dr. Ghobrial, can you speak to patients who are in the MGUS and smoldering phases?
Yeah, absolutely. So as you've heard already from Dr. Cho, we don't usually treat patients with MGUS and smoldering, but we do have a lot of clinical trials. And one of the questions that we have is, even if you submit a research sample, that's already part of a trial. Sorry, and I don't have coronavirus. So one thing we encourage you is being an active participant of your own care. And we're thinking of so many ideas and so many clinical trials for MGUS and smoldering. So again, talk to us, email us if you have questions. But even MGUS, when we say, yes, we don't treat you because your chances of progression are very, very low, 1% per year, we're thinking of vaccines that can prevent progression. Now that we're all thinking of COVID-19, can we have a vaccine? Think of it, can we develop vaccines for smoldering or for MGUS that can prevent progression? Can we use your immune system to overcome this small tumors clone that you have in your body and now restart the system so that those cells do not grow? So we've done a lot of work recently, again, from the PCROWD samples, where we've shown that the immune system changes even at the MGUS stage. So when we tell people who have MGUS, oh, this is benign, you're not going to have any problems, in fact, we find that the immune system already has changed even at the MGUS setting. So if we can restart that, if we can give you an early immunotherapy, whether it's vaccine, whether it's a new antibody, something that's not toxic and for a very short duration and can prevent myeloma from happening for you in the next 10 years, 15 years, then that's the goal that we have. For smoldering myeloma, we try to define, again, are you at high risk of developing myeloma in the next 2 years, what we call high-risk smoldering disease, or are you at a lower risk? And again, we have clinical trials for both of those. High-risk smoldering is more of an urgency. We think you're almost myeloma. We want to make sure we treat you correctly. We don't undertreat you. We don't cause clonal resistance. We don't think that we want to treat you just with one drug or two drugs. Sometimes we want to treat you just like overt myeloma. And that's a discussion that we have with everyone. So again, it's a big part of the discussion. It's a research initiative. We don't have the answer yet for all of those questions.
Perfect. And we will get later on speaking with Ethan about the importance of participating in clinical trials. So hopefully we still have Dr. Ghobrial. It looks like she went off for a second. There she is. Okay, perfect. Our next question was something that came up repeatedly in a variety of different formats. So I kind of tried to summarize it down into a single point, which is, what exactly are you looking for when you see lab tests and blood tests come through for a patient? When a hematologist says that a number is stable, I think some patients may get confused because they're seeing some type of a fluctuation. What is natural fluctuation? What is something to be concerned about?
Hearn, do you want to take that one?
Sure. So specific to myeloma, in making the diagnosis of myeloma, we look for four things in the initial lab tests. Myeloma is a disease that involves the bone marrow, and it can affect normal blood formation. So low red blood cell count or anemia is one of the hallmarks of the disease. They can also directly damage the bone and cause uh, holes, punched out holes, or what are called lytic lesions in bones. So we look for X-ray evidence of damage of this type. The two other lab signs that we often look at to make the diagnosis of myeloma are elevated blood calcium. So the damage to the bone releases calcium into the bloodstream. And then the last thing is that the abnormal protein that's overproduced by myeloma cells can affect the function of the kidney in many different ways. So renal failure or abnormal renal function is the fourth. And that's there's an acronym that we have for that. It's CRAB, C for hypercalcemia, R for renal dysfunction, A for anemia, and B for bone disease. So we call this CRAB symptoms. There are some other perhaps more subtle laboratory tests that a doctor will do in working up a new myeloma patient. And these are used to make the diagnosis. Now that's actually different from what's called the M protein. So this is a number, this is a word that a lot of myeloma patients become very familiar with. M stands for monoclonal. So the monoclonal protein is an abnormal protein. It's an antibody that's secreted by the myeloma cells. So there's a large mass of abnormal myeloma cells, and they all make the same protein, and this overproduced protein can be detected in the blood. And there's a couple of different flavors. There can either be a whole antibody or what's called light chains, and these are other terms that you may hear. But these are a barometer of the amount of disease activity in the body. So many times what we do is when we start treatment, we measure the M protein in the blood on a month-by-month basis to see if the number is going down. So if the number goes down, that's good. That it means typically that means that the disease is responding to treatment and bad cells are getting killed. And that's one of the criteria we use to define remission. So a lot of times you will hear myeloma patients hear things like your M protein's going down, or your M protein's very low, or it's stable, or it's undetectable. That's good. We always like that. And so this is one of the big features that we look for in lab tests for myeloma patients. There are other things like seeing the red blood cell count return to normal, the calcium level return to normal, things like that, that we also think are important. But those are some of the big ones that you'll hear and become familiar with as a myeloma patient.
I think any one other thing that many of our patients do look at when they're looking at all their light chains and their M spikes every month is when they see that the number changed from 0.2 to 0.3, they suddenly worry, is this really a progression? And then it goes back to 0.25. So those fluctuations, we consider that stable unless it's really increasing significantly and every time it's increasing, because it's normal that your body will change, that the fluids inside your blood will change. So being careful that we don't expect it to be a straight line. We do expect fluctuations, and that's normal. It's only when it's increasing significantly and it's going up from every time we measure it, or it's going down, which is a response, then that's always a very good sign.
Perfect, thank you. Our next question is related to that in a bit, but it's kind of taking it a step further. And I know this is something that you probably get a lot as well. How often should a myeloma patient receive a bone marrow biopsy? And similarly, how often should a smoldering or an MGUS patient receive one, especially if they don't appear to be progressing through lab values?
You want to take that one?
Sure. So anybody out there who's had a bone marrow biopsy knows that it is not a fun test. It can be very uncomfortable and painful. And believe me that hematologists take no joy in doing the test, but it is the gold standard, and it's important in many ways. It tells us how much myeloma there is in the bone marrow, and it gives us tumor cells that we can do very important genetic and molecular tests on to understand if it's changed, if it's becoming more aggressive, if it has taken on new features. And so for better or worse, that's the test we're stuck with right now. And how often is a different question. So at diagnosis, it should definitely be done. It's mandatory. Also, by the strictest definition, to make the diagnosis of complete remission after treatment, this does require a bone marrow biopsy for confirmation of the number of the myeloma cells in the bone marrow. A very good argument can be made that anytime one is thinking of changing or starting treatment. So if you think a patient who was in remission is now relapsing, that you should do a bone marrow biopsy. Or if you have a patient who's on a treatment and you're not sure if, or you don't think that treatment is working anymore and you're considering a change, that you should also do a bone marrow biopsy at that point. I think that in practical reality, it's very difficult to do that every single time. It's a lot to put patients through, you don't you need to weigh the potential benefit of learning whether there's new changes, molecular changes in the myeloma cells, for example, versus the risk and discomfort that subjects a patient to do the bone marrow biopsy. So it is an important test. It is the gold standard test now. We are hoping that in the future there will be tests that can replace it. For example, the kind of peripheral blood or so-called liquid biopsies that Irene's study is pioneering. That may someday replace bone marrow biopsies, but right now, unfortunately, that is the gold standard. And the likelihood is most myeloma patients will have to have more than one procedure during their journey.
Yeah, and I can explain a little bit what liquid biopsies is. So basically, we're taking your blood samples and trying to understand what happens in your bone marrow, but taking the picture from the blood. And I would usually say that in myeloma, we've been very lucky to actually have the first liquid biopsy as a biomarker of what happens in your bone marrow. That M spike, or those light chains that we're talking about, are a blood sample that tells us if your antibodies are going up in your blood, it means the cancer cells are increasing in your bone marrow. So we've had this biomarker of liquid biopsy for years and years before anyone started saying, well, let's use liquid biopsies. But liquid biopsies these days, what we mean by it is that we can actually detect the genetic changes that happened in your cancer cells in your bone marrow, but look at them in your blood. So why do we need a bone marrow biopsy? Because we want to look at your cancer cells and we look at them under the microscope and we can say how many cells are there, because if you have 10%, then you have smoldering myeloma. If you have more than 60%, then you have myeloma. If you have 0%, like we said, you're in complete remission. These are numbers. Then we look at the genetics, what kind of cytogenetics and what kind of FISH changes you have, which are the big changes in your chromosomes or your DNA. And we now can do fancier tests called next generation sequencing, where we can find point changes, point mutations in your genetics of your myeloma cells to tell us, is this a bad myeloma or is this an okay myeloma that's not going to behave as bad as the other one? And we can tailor your therapy based on that. So that's why we need the bone marrow. Now, can we use that information from the blood? We're developing other methods called liquid biopsy, as we said, circulating free DNA. Basically, your cancer cells, when they die, they shed the DNA into the blood. So it gives us a fingerprint of what happened in the bone marrow. And we can actually pull that DNA from your blood and get the same information of the bone marrow. So in the future, hopefully we will do only peripheral blood samples, or maybe even do just one bone marrow sample and then track the rest of your genetics from the peripheral blood.
Perfect. And I just want to give a shout out to all of our PCROWDers who are watching who have submitted bone marrows to our tissue banking study. We give you a big round of applause because those are very, very precious, and we really appreciate when you submit them. So thank you. Okay.
As well as the blood samples too.
As well as the blood samples. Yeah, absolutely. Okay, so our last treatment-related question for the time being is, we do have some patients both in the precursor stages as well as in overt myeloma who also have secondary malignancies. For example, some patients with breast cancer who then go on to develop myeloma. How should the conversation with their hematologist be in relationship to their other conditions, and what should the conversation be about developing other therapy-related conditions such as AML?
Yeah, that's a good question. So the treatment of myeloma takes a village, as it is. So it's not just the hematologist or oncologist who's treating the patient. It's their team, their nurses and nurse practitioners. Typically, because of the complications of this disease, you need to have an orthopedic surgeon or a neurosurgeon, a kidney specialist. You often have to get an endocrinologist involved because we use medications that can affect metabolic functions such as the endocrine system. And so it's truly multidisciplinary care from the outset. So having a secondary malignancy just adds another member to that team. So for patients who had previously other cancers and then were diagnosed with myeloma, if they're getting treatment for their other cancers, there should be dialogue with the physician who's treating the other cancer, because there may be common drugs that can be used for the treatment of both. You want to prevent overlapping toxicities that may make side effects worse, and you want to be able to monitor and appropriately deliver supportive care such as growth factors and transfusion support and so forth. There is a risk with many of the drugs that we use for myeloma to develop another type of cancer. Unfortunately, many chemotherapies for many types of cancer have that risk. We also often use radiation treatment for the treatment of bone disease, and that carries a risk as well. So we work in collaboration with other oncologists and hematologists. For example, a lot of myeloma patients may develop secondary blood cancers, and we will work with other specialists in order to make sure that those are treated as well.
Yeah, and I would probably say that one of the studies that we just did recently, and it will be published soon, hopefully, is looking at something called clonal hematopoiesis of indeterminate potential, or CHIP. So again, just another new name here. But we found that there could be stem cell mutations. So just like you have small changes in your DNA, you can actually have small changes in your DNA in your stem cells, even before you start myeloma therapy. But it could also happen from chemotherapy, from breast cancer treatment. So I can envision that someone already had some damage from another cancer therapy, or even from, as we get older, we start getting some of those aging mutations, and then we start giving you Revlimid or Melphalan for transplant or other things that can cause more problems to those stem cells. So we actually now are starting to look at those CHIP mutations and whether they can be important for us to measure before you go for chemotherapy, as in transplant, or whether they're important to track when you're on Revlimid for a long time. So definitely we're working on measuring those to make sure that we don't have secondary leukemias in the future for many people with myeloma.
Perfect, thank you. And this actually is going to be a great transition to our research-related questions, because it's going to tie in some of those new clinical trials and research options with our question about bone marrow biopsies and cytogenetics. And this is about the relationship between having particular high-risk cytogenetic features, such as a 17p deletion. How do you know in general if you are high risk, and what does it mean to be high risk?
Well, that's a good question too. It's a question that a lot of investigators are asking ourselves all the time, because we do know that certain genetic changes in the cancer cells, so these are not typically things that people are born with, but these are mutations that occur in the cancer cells. We do know that certain mutations or genetic changes are associated with higher risk. In other words, the disease either is more aggressive or less responsive to chemotherapy, and we have to be a little more vigilant and aggressive in our management of these patients. But the problem is we don't have a perfect system yet. So even patients, we know that within patients who have a certain genetic change that is considered high risk, there are still many patients in that group who do just fine with regular chemotherapy and regular consolidation and regular maintenance. So it's pretty clear that those things that we consider to be markers for high risk are just the first step. And we need to understand in that context what else determines whether a patient is really high risk or not. So that's definitely an area of ongoing research. We are confident that these genetic changes are associated with high risk, but they're not a perfect predictor of high risk. So a lot of research that we're doing now, and this is, I'm sure, part of the PCROWD and PROMISE study as well, is understanding in the context of those genetic changes, what other factors give us a real picture of the risk for an individual patient.
Yeah, absolutely. And even we will have a paper that just got accepted in JCO, and that's because of the PCROWD work that all of you have contributed to, that tells us that for the first time, we can actually take all smoldering myeloma patients and look at the high-risk features in their genetics. So whether they have 17p deletion, whether they have 414, whether they have something called KRAS or NRAS mutations or MYC amplification or translocation, those are the patients who progress very rapidly to overt myeloma. So the hope is that we can measure those and then tell you are at high risk of developing myeloma. But what we just heard from Dr. Shaw is people who have overt myeloma, people who have myeloma right now, relapse or upfront, when you have a 17p deletion, when you have bad cytogenetics, we want to make sure that we may treat you differently, that we want to add something more so that we don't just treat the same way. And I always think of it, we know so many changes in myeloma. We know that myeloma is not one disease, it's actually multiple myeloma. Some people have very different genetics compared to others, yet we end up treating everyone almost the same way. Everyone gets RVD or KRD. So the future is that we do something called precision therapy, where we actually, and in fact, MMRF is the pioneer of that with the My Drug study. We look at your genetics, then we give you a specific treatment for that. And we're almost there with this because people who have 1114 translocation right now, we give you something called venetoclax. It's a drug that's specific for that type of translocation. I would probably say a 17p deletion, a p53 mutation. Hopefully we start thinking of immunotherapy early on. Hopefully we start giving you a bispecific, a CAR T therapy early on so that we prevent progression in your case rather than giving you the same old therapy that everyone else does very well with, but you may not do very well with. Again, these are ongoing clinical trials, so we will get the data, but yes, we try to treat you differently because your disease is a little bit more aggressive than others.
Perfect. Thank you so much. We are going to transition to speaking with Mr. Ethan Hawes right now. I just want to make sure we have time to get through everything. So I will just transition to this. All right. Hi, Ethan. How are you?
Good, Annie. How are you?
Good. Thanks so much for being here. It does take some guts to get in front of a bunch of people and talk about pretty personal experience, so I really appreciate it.
Thank you. I'm excited to be here.
All right. Yes, I can. Perfect. Okay. So I was just hoping you could start by giving a little bit of background on your story or personal experience with myeloma.
Yes, thank you. And going back to what Dr. Cho had mentioned about it takes a team, that is really what it has been over the last 7 years. And I feel very fortunate, very grateful to have this PROMISE study team that is really working at a different angle and trying to prevent multiple myeloma from progressing from that state of MGUS smoldering to multiple myeloma. Because when I think back to my experience in 2013, when I innocently tripped over a curb in Spain while studying abroad, I felt a shooting pain shoot up my hip into the ball and socket joint. And at that point, that's when probably I wonder when I was at that MGUS stage or that smoldering multiple myeloma. And then during January in 2013, while studying abroad and training for the Madrid marathon in April of 2013, I started to experience this really severe lingering hip pain in my hip, in the ball and socket joint in my hip. After getting back to the United States, it got to the point where I could barely put any weight on my hip. The pain was so severe and so nauseating too, that I finally went in and went to the hospital entrance locally in Southern Maine, and basically was wheelchaired to get an X-ray. And very fortunate, very quickly, they mentioned the orthopedic surgeon. There was a test. The X-ray revealed that there was something suspicious. I was referred down to Dana-Farber, where I had a consult with my orthopedic surgeon, Dr. Reddy, at Dana-Farber. And really within a 2-week time frame, it went from suspicious lesion to a fist-sized plasmacytoma in my right hip, which was causing so much of that pain. And then that's one of the reasons why I'm grateful for Dana-Farber and just how quick and how on top of it that they were. After that point, that's when the plasmacytoma went to multiple myeloma through further testing. And at that point, that's when the treatment of radiation, chemo, stem cell transplant really got put into place.
Thanks for giving us that background, Ethan. I'm sure that was all very frightening, and you are quite young to be a myeloma patient, so you have a very special story to share with people, and I think are kind of an indication of the importance of screening and screening early. Granted, you were quite young when you did get this diagnosis. Did you ever have to go through a bone marrow biopsy? And you said you'd gone through a stem cell transplant. Those two words, I think, are pretty scary for a lot of people, and a lot of our patients spend a lot of time preparing for one or the other. How did those work for you? And did you have any strategies you can share about what coping with that meant?
I was, like you mentioned, I was 22 when I was diagnosed, and that was completely overwhelming. I felt terrified. Fortunately, though, I've always had great people around me, whether it's healthcare professionals, friends, family. And in that moment when I was diagnosed with multiple myeloma, I really did feel like I was in great hands, and that the team at Dana-Farber had my best interest and really was going to take me through a process that I trusted. I trusted them, and that's why I went to the bone marrow biopsy that summer, 2013. Because I was in so much pain already, I didn't really think too much about the bone marrow biopsy. And it wasn't that it was very uncomfortable, but what it felt like was if you go fishing and you fill the fish, take the bait, it kind of felt like that type of tension. As far as the bone marrow biopsy itself, it was a quick procedure, 10 minutes. It was about 30 to 45 minutes from start to finish. And I remember my dad was in the room, so I held his hand during it. And that I really focused my mind on something completely else other than what was happening. For example, I was going to the yardstick, the yard brewery down the street afterwards. So I was thinking about that, and just that kind of helped deviate from what was going on. And I knew that the reason for the bone marrow biopsy was to really understand my diagnosis at the most cellular level. And so that would ultimately create the best treatment moving forward. And as far as the stem cell transplant, that was something which I now just thinking about, my team put into place. I like bit-sized pieces. Like at first it was the radiation, then it was hip surgery, then chemo. I didn't learn about the stem cell transplant as much until later on. And I knew that was kind of going to be the exclamation mark to my treatment. And so I felt pretty well prepared going into that at that point. But you're right, that stem cell transplant was a very difficult procedure, and mentally, physically, it was exhausting. But the lessons I learned from the stem cell transplant, ironically, have kind of helped in a situation like this. Being in that self-quarantine, you learn so many things about yourself and how to get through instances like that. So the things that you hear now about infections, like washing hands, nutrition, exercise, like those are things that multiple myeloma patients, and I've been doing so much ever since 2014 when I had the stem cell transplant. And so once you get through the ups and downs to the diagnosis, then you start to see all the silver linings that are coming into place. And like you said, thank you. Yeah, no, it's great to be able to be 7 years out now and be able to give that back.
Awesome. That's incredible. Thank you so much. So you actually told me recently that you are joined to serve as a mentor for the brand new MMRF Myeloma Mentor Program. I believe this is for newly diagnosed myeloma patients. Could you just clarify what the benefits of the program are, and why should participants or patients participate in this program or other mentoring programs, and how would they go about doing that?
Yeah, no, I'm extremely excited for that. I will be serving as a mentor, and I think one of the most important reasons is the information. There's a lot of information about multiple myeloma. Some of it is, and that can be overwhelming to a patient. It was overwhelming to me. So really what a mentee would be able to do is get the information from someone from the MMRF, and for someone who was in the midst of the multiple myeloma diagnosis for 3 years of 2013, 2016, I really had some setbacks, and now I'm in a place where I'm able to give that experience, give my perspective from what I learned in that instance, and be able to help try and guide and serve as a trusted advisor and be able to give objective perspective to it. Another reason that it could be that this is very beneficial is it's no cost. So instead of having to go, like, unfortunately, I get so much value out of patient educations, patient symposiums, conferences, but if those aren't being able to happen right now, you still need that information. And with the myeloma landscape evolving as quickly and as rapidly as it does, there's always new information, new updates that need to be given. And really, at the end of the day, it's about being able to give back. And it can be lonely, especially with how many complexities and nuances there are to the multiple myeloma diagnosis. And this is something that I wish I could have been able to connect with somebody. And that was my own, I didn't have that simply because I was 22 and going online and seeing that there wasn't any other 22-year-olds or anybody else in my age group really. That is now kind of one of my motivators, and that I have gone to a point where I can help support somebody else going through a similar experience, whether it is somebody newly diagnosed or a caregiver as well, because they deserve just as equal of attention and information too. So the MMRF, they have great resources, and I'm excited to be able to funnel that information and along with my own perspective. And so thank you. Yes.
Awesome. And we will talk a little bit more about the MMRF and their reaction to the COVID-19 crisis, as well as some other programs that they offer in a little bit. But Ethan, I have 2 more quick questions for you. First of all, I want to do a plug for you. You are our first PROMISE study ambassador. The PROMISE study, as we mentioned, is a nationwide study, and we are attempting to recruit a lot of participants. So it's a pretty monumental task, and having patients like you, or even family and caregivers of patients, support us by traveling to events, speaking on behalf of the PROMISE study, and really communicating with people the importance of screening early and being involved in research is extremely important. So I was wondering if you could just comment on what the PROMISE study means to you, and what you're hoping your involvement is going to look like moving forward.
What it means to me is that there's a group of dedicated, passionate healthcare professionals that is really trying to do something innovative, something completely new in the myeloma, with multiple myeloma. I mean, if you look at from 2000 to 2020, just the 5-year survival rate that has increased from 34% to 50%, what it is now, overall survival. And as mentioned, it's so exciting to see the treatments that are coming out and extending that overall survival 5 years. And I know that at some point there's going to be that cure on the back end for one of those treatments. And it's equally as exciting to see that dual prong approach, and that there's that focus and that initiative at the very beginning before it even can potentially get to multiple myeloma. So if you can create that separation and that gap to figure out those patients that are at ultra high risk and be able to get it from the very beginning, I mean, it's incredibly exciting. And so what it means to me is, again, that there's that focus and there's that energy to a cancer diagnosis that at one of a patient symposium, I heard a hematologist say that multiple myeloma is one of the most complex and sneaky diseases. And so that there's a group of people and physicians and healthcare practitioners, business workers that are trying to get in front of it, it just shows that it shows that we're being thought of, and that there is always going to be efforts in trying to help multiple myeloma patients in so many different ways. So it means a lot to me.
Thank you, Ethan. Our team is really excited about the PROMISE study, and I want to just also say that we did actually speak with Mr. Tom Brokaw, who is an acclaimed journalist and also a myeloma patient. He was on the evening news for years, and I'm sure most of you recognize his name. We do have a video interview with him on our website, as well as on our Facebook page. Our website's on the link at the bottom of this video, and you can also find our Facebook page through that link as well. So we have a lot of really great people pushing for the PROMISE study. And we'd love to have even more of you on board. Perfect. But now I'm gonna start with one question with Ethan to transition to, I think, the part of this webinar that everyone has been waiting for, which is talking about the COVID-19 pandemic. But Ethan, I wanted to start with one question for you first. I think your analogy talking about recovering from a stem cell transplant and being a cancer patient in general and having to deal with life as a cancer patient and similarities to being someone at home during the COVID-19 pandemic is really interesting. So as a myeloma mentor and a patient advocate, what is your perspective on how to stay safe, and not only safe, but sane during this pandemic?
It's a great question. And just quickly to back up a second, when you mentioned where I see the involvement too for the PROMISE study, I definitely see myself continuing advocating and just getting that awareness out there, because it's incredible the work that you've done. Both yourself, Julia, Nader, Ali. It's really exciting. So I appreciate all the effort that's gone into it, and Dr. Ghobrial, of course, as well. So thank you. How have I stayed safe and sane? I think that one, I've tried to keep a routine. Going. That's been the biggest thing. But from the stem cell transplant, what was most difficult was the disruptance to everyday life, and knowing that there was kind of the world was continuing to go on. And I felt like as a 23-year-old who was just trying to find his identity, that was something I didn't have necessarily. So it really took a long time to get that back and to be able to focus on myself. And once I began doing that, I started to pick up habits and good patterns of ways to do that. And I think that keeping a routine is really important, and staying sane is we have an opportunity now, like we're doing, and with focusing on friends and family, focusing on the people that I have in my life now, it's no different than how it was back in 2014 after the stem cell transplant. And I think that multiple myeloma patients, that this probably brings up a lot of fear about going outside. It kind of brings up some memories again. And at the same time, it also is like, we've been through this, and this is something that if we're safe, if we're wearing gloves and we're just being extra cautious of the environment that we're in, it's something that we've already been doing. Like I don't try and overextend myself even before the coronavirus because of my immune system, because I want to make sure that I'm in the best optimal overall health, both mentally and physically. So again, yeah, I would say getting a routine, and also knowing that this is temporary, that this isn't something that's going to last, just like the recovery from a stem cell transplant. You are going to get back on your feet. We will be able to keep on moving forward. So routine and knowing that it's temporary, and focusing on the important people in your life.
Wise words, Ethan. Thank you. So thanks, Ethan, for being with us today. If anyone has any specific questions for Ethan, you can comment them and we'll get to them at the end. But for now, I'm going to pop the two physicians back on to ask some more COVID-related questions. So thank you, Ethan.
Thank you.
Perfect. All right. So I think we're going to move on to probably the two biggest questions for this webinar. The first is, in general, what are hematologists recommending for our MGUS and smoldering patients about getting their regular lab work done or going in for appointments during the COVID-19 pandemic, and kind of extending that to even higher risk patients, our MM and WM patients, and our MM and WM patients with secondary cancers?
Yeah, it's a great question. And again, I just want to say thank you, Ethan, for an amazing discussion now about how to deal with the COVID-19. It's really amazing. And I'm sure all of our patients who are listening in and their family members appreciate that. It's hard for all of us, including us as physicians, to deal with this and to try and figure out when to tell a patient not to come to see us, and what to do with the care. But in general, there are recommendations that came out yesterday from the International Myeloma Society, so you can see those. But we try to keep things consistent, as in saying, if it's a risk for you to come in to a clinic, then let's try to keep you at home safe. And that includes people who are asymptomatic symptomatic, like MGUS and smoldering, we're trying not to have you come into the clinic to get your blood drawn. We're trying to keep you at home. And again, this is maybe one of those positive things that we'll learn. Telemedicine, virtual consults, virtual phone calls. We've been doing a lot of those now, and we're hoping that in the future, we would actually keep up that CPAP will become all virtual, and you can live in Florida or California or anywhere else and still have your appointment with us. So maybe that's one positive thing. But if you are on therapy, we're starting to say, is this therapy essential? And do we need to bring you in or not? And can we switch you to an oral drug that's, again, less coming into the clinic, less exposure to us and less exposure to COVID-19. And again, these are recommendations that are coming out that will help us as we go through these few months and hopefully less than that to try and overcome this pandemic. But again, we'll learn from it in the future how to be more resilient and how to treat our patients in very different ways. I think clinical trials will also change. We're learning now how to extend clinical trials so that people don't have to come in for those frequent visits, to come up with innovative ideas of how to recruit patients without making them come into clinics. So hopefully we will be much stronger and much better in the future. But for now, keeping you safe, less visits, and trying to reach out to us virtually as much as possible is the message we're doing right now.
I'd just like to echo what Irene said and emphasize that patients should speak with their physicians, with their treatment team. There's risks and benefits to every decision. And obviously the risk part has changed significantly with the onset of the COVID-19 pandemic. But there are also real concerns about patients continuing on treatments that they absolutely need, and ensuring that they can get those treatments in the safest way possible. So guidelines are great, and we like to have them and we use them. But ultimately, these are decisions that should be made between patients and their physicians, and we encourage you to speak with your treating physician and come up with a plan that is best suited for your individual care. We at the MMRF, we created a web resource with information regarding COVID-19. We're updating this regularly. You can find it at our website. It's www.vmmrf.org. So hopefully that will be helpful for people out there who have questions.
Perfect, thank you. And I also put the link to that, to the MMRF website, the specific coronavirus portion of it on the video below. You kind of answered this question, but I'm going to ask it in an even more specific way, simply because I know our PCROWD and Promise participants have been reaching out to our staff with this question. In the news and when we're talking about COVID-19, there's a lot of talk about people who are high risk or immunocompromised and people who aren't. Are our MGUS and smoldering patients considered high risk individuals, particularly if they're not on treatment?
Yeah, it's a great question, and we really don't know the answer. We know that your immune system is important to fight any infection. We know that in general, even at the MGUS stage, you're starting to change your immune system, although not as bad as you get all the way to overt myeloma. So it may be that you're okay in an immune system, and then it starts getting worse and worse until we get to myeloma. And then when you're on therapy, especially dexamethasone and other therapies, that can suppress further your immune system. We actually have a study that we're going to try to do on samples of patients who are exposed to COVID-19 or who have COVID-19 positive results, and trying to ask the question, what is the immune system of a cancer patient versus non-cancer patients? Can we predict early on who will develop bad disease or not? Now, having said that, are you at risk is one thing, but also, are you at risk of getting all of the bad complications that happen later on, which are actually your immune system is revving up and going all to the extreme of the other side of trying to overcome it, but also killing your own cells and your own good cells. And that's what's killing many of the patients. So we're also asking the question, are there therapies that can actually inhibit the immune system reaction at that time? And in fact, some of our cancer drugs are potentially being tested in those areas. So again, it's a very complex area. We're all trying to be part of that initiative to help understand who is at risk of getting worse disease, who's at risk of developing it or not, and how can we all be protected.
Perfect, thank you so much. I am going to start we've officially finished the portion of our webinar that was based on questions submitted earlier. I'm going to start doing a couple of the rapid fire questions that were coming through on email and Facebook. So these will be, there's a lot of them, so we're going to kind of do them relatively quickly. And I'm sorry if we don't get to yours, but thank you everyone for listening in and for commenting your questions. This has been really great so far. So beginning with the first question that we got submitted earlier in the webinar, do you always recommend treatment when a patient meets the biomarker criteria, regardless of that person's health status?
Hearn, you want to answer?
Yeah, that's a good question. So as I outlined earlier, there are diagnostic criteria for symptomatic myeloma, which is typically the trigger for starting treatment. And I would say as a general rule of thumb, the presence of any of those symptoms is a strong indicator that treatment is necessary. Having said that, every patient is different and every patient's needs and requirements are different. So there are situations where we have to take into consideration other factors. For example, in those rare instances where a patient is pregnant when they're diagnosed, or if they have another medical condition that needs to be urgently addressed. So we don't want to be inflexible in our approach, but we do know from very good historical data that if patients develop one or more of those symptoms, they will benefit from the treatment. So the short answer is yes, they do need to be treated, but that's not a ironclad and immediate rule.
Perfect, thank you. Can you comment on the immune suppression effects of DARA therapy? In particular, are patients who are currently receiving DARA, is that necessary during the COVID-19 outbreak?
You want to take it? Or?
No, go ahead.
So daratumumab, Darzalex, is a very interesting agent. It's not a drug, it's an antibody. And it's an antibody that attaches to a target that is present on the surface of myeloma cells. But that target is also present on the surface of many other types of cells, including normal immune cells. So what was originally thought to be an antibody that targeted just myeloma cells to get them killed, it turns out it may have very complicated effects on the immune system. And one of those things may be beneficial. It may activate T cells, which are one of the killer cells of the immune system that goes and finds either infected cells or cancer cells and kills them. But what was also observed is that patients with who are getting Darzalex or daratumumab, there was a small but real increased risk for two things. One is reactivation of hepatitis B, which is a viral infection and is usually controlled by T cells. And the second is that there was a small increase in lung complications, so lung infections like pneumonias, other types of inflammatory effects in the lungs. So it has likely immune stimulating properties, but those immune stimulating properties may lead to either deficiencies or overactivation in other areas. So given the concern about lung complications, particularly pneumonias and pneumonitis in COVID, for patients who are in remission on Darzalex therapy, we have planned to skip a lot of these infusions. If patients are on active therapy because they still have symptomatic disease, again, this is a discussion that you should have with your practitioner. There is certainly potential for benefit to continue the treatment, but there are also risks. So these are discussions that you should have with your practitioner and your myeloma treatment team and make that decision as a shared decision.
Perfect. In a similar vein, there are some MGUS and smoldering patients who are on bisphosphonate therapy. Is that similar to the therapy that you would receive on a clinical trial, and does that help with preventing progression?
So bisphosphonates have been tested for many years, actually, to see if it can prevent progression or not to overt myeloma. And in fact, a lot of those studies were published years ago. They did not show that there is benefit to prevent myeloma progression, but that they did have a benefit of something called decreasing skeletal-related events, which means cutting down on the number of bone lesions, cutting down on the number of bad lesions you develop in myeloma. So in fact, yes, we recommend that you get bisphosphonates, not as often as we used to give it a lot. So we don't do the monthly visits. We don't do ongoing forever. We try to cut it down because there is risk from getting too much of bisphosphonates, but there is benefit from them to prevent or delay progression of lytic lesions. It does not prevent myeloma progression itself.
Thank you. Some more treatment-related questions. There seems to be some research, and there's definitely some ongoing thought on patients who are on statins, various types of statins, and that having an impact on progression. Can you speak a little bit to that?
Yeah, it's hard to know. There are so many things that we think could potentially change the metabolism of cancer cells. Statins, metformin, so many other things, intermittent fasting. There are so many questions, the microbiome, all of these questions are being asked. And in fact, the School of Public Health with Catherine Mernick, who's one of our leaders in the Stand Up to Cancer grant that we have, is working with us on trying to ask those questions in active clinical trials for MGUS patients.
Thank you. All right, this one's a more general question. I think it's for probably those people who are living outside of Boston right now. Are you, Dr. Ghobrial, are you seeing the virus affecting cancer care in general in the Boston area? Can you kind of describe what that looks like for Dana-Farber and maybe the area that you are in right now, and potentially the demand for medical supplies?
Yeah, it's not New York, I can tell you that, and thank God, but it's definitely a significant change for us. We're all on a list to be on call, to be available for the Brigham inpatient service if needed. Right now, we're trying to change our management that many patients are virtual consults or virtual visits. Even if we're giving them chemotherapy, we're trying to avoid seeing them in person if we can, just to avoid the contact and maybe exposing them to us and to others. It has completely changed the way we manage our patients. It has really disrupted a lot of things. We're hoping we will learn a lot from that. We're hoping that there will be positive coming out of it. As I said, telemedicine, virtual consults, changing clinical trials, management, learning how to do a lot of Zoom calls, and a lot of our management of patients is now with Zoom consults. So it's a very different world. We're hoping that everyone stays safe. We're very fortunate that the Boston area, Dana-Farber, Brigham, MGH, all of them are just amazing hospitals. I always say I'm lucky that I live here in case I am very sick. But we're hoping that we will all look back at this and say we've learned a lot. There's a lot of research that we're doing on this. And in fact, the whole Boston area has a consortium, basically, that we're all working together, all of the hospitals, to collect all of the samples from the patients with COVID-19 and ask big questions so that we can improve on the therapy, but also improve on understanding who will develop bad disease.
Perfect, thank you. And you can also, again, check out the MMRF site listed on the video here for more on the COVID-19 and myeloma diagnosis. So I think that I have selected 2 final questions. And if you have any other ones, you can always email our team or reach out through either of our websites. We're pretty available. So feel free to do that if you have anything that comes after we are done here. But one of our last 2 questions is, do you change your therapy choices for patients who do have high-risk mutations such as T1114, and what helps you make that type of decision?
Well, there's a couple of ways this can affect treatment. So certain genetic changes like T1114 can predict response to certain types of medications. So for example, there's a drug called venetoclax, which is FDA approved for lymphoma, which is being tested in myeloma because patients with the 1114 translocation have a high response rate, higher than expected, and that it can also be combined with myeloma drugs such as Velcade. So if there's clinical trials available that act on specific genetic changes, that's how it's going to affect our practice right now. We don't have generally applicable treatment strategies that are based on specific genetic changes yet. This is one of the things that's under investigation in a number of different clinical trials, including the venetoclax trials that are ongoing, and also the MMRF is sponsoring a trial called My Drug, which Irene mentioned earlier, where we use sensitive genetic tests to find mutations that can be treated with specific drugs. And there's a number of approaches like this. So we do need that information. It can help guide us either putting patients on clinical trials or, if possible, getting FDA-approved drugs for what are called off-label indications. So that we're just using this knowledge and this information to broaden the treatment choices for individual patients.
Great. All right. And we're going to close on our last question. Our very exciting question that I think is very confusing for people very often. Can you please explain what free light chains are, what the ratio means, and how to really determine what increases mean for your care?
Irene, I'm going to let you do that.
No. I was just going to say that's yours.
Okay. So I guess Irene knows that I'm an immunologist by training. So the M protein that I mentioned, so let's back up. Myeloma is a disease of plasma cells. So what are plasma cells? Plasma cells are actually part of your immune system. So this is a disease of the immune system. Plasma cells are the cells that make antibodies. So normally you have hundreds of thousands of different plasma cells. Each one makes a unique antibody. So in your blood, you have hundreds of thousands of different antibodies. When one plasma cell starts to grow and divide and reproduce itself out of control, as in MGUS and myeloma, all of those copies make the same antibody. So they're overproducing this massive amount of antibody, which is then detectable in the blood as the M protein or monoclonal protein. Now, an antibody molecule is actually 4 molecules. There's 2 heavy chains and 2 light chains. And they're all mushed together into one Y-shaped molecule that normally is produced to stick to viruses and bacteria and so forth. So normally, when a normal plasma cell makes about the same amount of heavy and light chains, so that they're all assembled in the cell into a complete antibody and then secreted. For reasons that we don't really understand that well, the vast majority of abnormal plasma cells, of myeloma cells, overproduce light chain relative to the heavy chain. And the reasons for that are not really well understood, but they do. And those light chains get secreted into the blood and can also be detected by a different test than the one that looks for M protein. So there's 2 flavors of light chain. One is called kappa and one is called lambda. Normally, human beings make about 2/3 kappa and 1/3 lambda. So the ratio in normal people is roughly 2-to-1. There's a normal range, but it's approximately 2-to-1. Then so a myeloma cell is either kappa or lambda. So myeloma patients vastly overproduce either kappa or lambda. So then the ratio is either going to be very, very high or extremely low, depending on which one it is. So that's where kappa and lambda light chain come in. They're measured in the blood, so the total amount of kappa and lambda are measured, and then the ratio of kappa to lambda is usually reported in the report. There are also variants of myeloma that do not produce a whole antibody, a whole M protein. They only make kappa or lambda light chain. So then that becomes the primary test that we follow in the blood to measure the response to treatment.
Perfect. Thank you. All right, I'm going to bring everyone back in. Thanks for submitting your questions and for joining us for this chat. I'm going to bring Ethan in. Perfect. We've got everyone back in. So I just want to bring out a couple points again to reemphasize. Number one, if you're a PROMIS or a PCROWD participant and you haven't heard from us, please check your email. We are communicating via email. We'll be doing so regularly in the next couple of weeks. You can also reach out to us via that platform as well. Please invite your friends and family members to participate in the PROMIS study. We need you. We need your help to not only do this type of research, but also to spread the word about this type of research. If you have questions about what your participation would look like, feel free to email us or to call us.